Good morning. My name is Joel Marx, and I'm speaking to you from Cleveland, Ohio. I am chairman of Medical Service Company, and I'm honored to be able to greet you this morning for what I am sure will be an outstanding day of education and learning. Our dedicated team at Medical Service Company has been working for months to bring you the right mix of speakers and CEUs necessary to continue your service to patients and the profession. I salute you all for investing in not only your future, but being a healthcare hero during this particularly challenging time. My parents, Gene and Merle Marx, started Medical Service Company in 1950, and I have spent my career expanding our services and using technology to improve patient care. My mom, Jean, was a great ambassador for our organization and loved to spend the day in person with so many of you at our annual seminar. She passed away several days before the program in 2004, and it was renamed in her memory. We are so pleased to be able to continue to offer this program virtually through the generous support of our sponsor partners, including manufacturers and service providers from around the country. Please thank them and support them. Medical Service Company now serves patients throughout the Midwest and eastern parts of our nation and is continuing to develop services to provide ventilator and respiratory care, treat sleep apnea and diabetic patients, and provide home medical equipment. Our outstanding healthcare team has embraced technology to transition to new ways to connect during the pandemic, and we are proud of this outstanding group of men and women. Most of our team of 400 service providers are working remotely, located across the nation. We continue to grow our team, serve our patients, and partner with hospital systems, healthcare providers, and insurance companies. I hope you enjoy the program today. Though we are distant, we are all together today, dedicated to our patients. Our team is vaccinated. We hope you are as well. Thanks for all you do to make our communities stronger, healthier, and safer. Enjoy the day.
Thanks, Dad. Hello and welcome back to our 21st annual Gene S. Marx Memorial Education Forum. My name is Josh Marx, and I'm the Vice President of Business Development for Medical Service Company. Last year, we reimagined this event after 19 years offering it in person in Cleveland. The response was overwhelming, with over 1,000 registrants representing 48 states and 2 countries. Like last year, today's event offers a similar class of healthcare professionals spanning the globe. We are honored to provide a premier education event in the sleep and respiratory disciplines for some of the most important healthcare heroes in our communities, you. We have an action-packed day for you with 10 speakers from distinguished universities, health systems, and supporting organizations. Before we get going, let me give you a quick lay of the land for today's program. This morning, we'll have 4 sessions for all of you to attend, the 4th being our keynote panel. Then, after a 30-minute break, there will be concurrent sessions running the remainder of the day, one for the sleep discipline and one for respiratory. Throughout each session, you can submit questions under the Engage tab just above the presentation screen. Speakers will address questions following their presentations as time allows. All sessions have been approved by the AARC and all morning and sleep sessions approved by the BRPT for continuing education credits. After a few minutes into each session, you will see a pop-up screen inviting you to evaluate the session and speaker. If you miss the pop-up or wish to fill out the evaluation later, simply click the blue button called Check-in Survey located on the screen above the name of the presentation. At the end of the day, you'll be able to download your certificate from within the conference site. Before we kick things off, I'd like to thank all of our speakers, sponsors, and DME partners. Sponsors, thank you for your support of this event. we would have a very difficult time offering this type of event without your support. We all have a choice of who we do business with. Please consider these manufacturers and suppliers. They clearly believe in the DME channel and investing in home care. DME partners, it's inspiring to see us band together for the benefit of our partners and patients. Today, we are all one team. Because of the valuable information being shared by our world-renowned speakers today, we will be better equipped to care for the millions of Americans with sleep and respiratory conditions. One more thing. Before each session, you're going to hear a little bit more about MSC from a few of our team members. To learn more about anything you hear and how we can support you and your patients, visit medicalserviceco.com. Now, let the forum begin. Thanks, Dad. Hello and welcome back to our 21st annual Gene S. Marx Memorial Education Forum. My name is Josh Marx, and I'm the Vice President of Business Development for Medical Service Company. Last year, we reimagined this event after 19 years offering it in person in Cleveland. The response was overwhelming, with over 1,000 registrants representing 48 states and 2 countries. Like last year, today's event offers a similar class of healthcare professionals spanning the globe. We are honored to provide a premier education event in the sleep and respiratory disciplines for some of the most important healthcare heroes in our communities, you. We have an action-packed day for you with 10 speakers from distinguished universities, health systems, and supporting organizations. Before we get going, let me give you a quick lay of the land for today's program. This morning, we'll have 4 sessions for all of you to attend, the 4th being our keynote panel. Then, after a 30-minute break, there will be concurrent sessions running the remainder of the day, one for the sleep discipline and one for respiratory. Throughout each session, you can submit questions under the Engage tab just above the presentation screen. Speakers will address questions following their presentations as time allows. All sessions have been approved by the AARC and all morning and sleep sessions approved by the BRPT for continuing education credits. After a few minutes into each session, you will see a pop-up screen inviting you to evaluate the session and speaker. If you miss the pop-up or wish to fill out the evaluation later, simply click the blue button called Check-in Survey located on the screen above the name of the presentation. At the end of the day, you'll be able to download your certificate from within the conference site. Before we kick things off, I'd like to thank all of our speakers, sponsors, and DME partners. Sponsors, thank you for your support of this event. We would have a very difficult time offering this type of event without your support. We all have a choice of who we do business with. Please consider these manufacturers and suppliers. They clearly believe in the DME channel and investing in home care. DME partners, it's inspiring to see us band together for the benefit of our partners and patients. Today, we are all one team. Because of the valuable information being shared by our world-renowned speakers today, we will be better equipped to care for the millions of Americans with sleep and respiratory conditions. One more thing. Before each session, you're going to hear a little bit more about MSC from a few of our team members. To learn more about anything you hear and how we can support you and your patients, visit medicalserviceco.com. Now, let the forum begin. Thanks, Dad. Hello and welcome back to our 21st annual Gene S. Marx Memorial Education Forum. My name is Josh Marx, and I'm the Vice President of Business Development for Medical Service Company. Last year, we reimagined this event after 19 years offering it in person in Cleveland. The response was overwhelming, with over 1,000 registrants representing 48 states and 2 countries. Like last year, today's event offers a similar class of healthcare professionals spanning the globe. We are honored to provide a premier education event in the sleep and respiratory disciplines for some of the most important healthcare heroes in our communities, you. We have an action-packed day for you with 10 speakers from distinguished universities, health systems, and supporting organizations. Before we get going, let me give you a quick lay of the land for today's program. This morning, we'll have 4 sessions for all of you to attend, the 4th being our keynote panel. Then, after a 30-minute break, there will be concurrent sessions running the remainder of the day, one for the sleep discipline and one for respiratory. Throughout each session, you can submit questions under the Engage tab just above the presentation screen. Speakers will address questions following their presentations as time allows. All sessions have been approved by the AARC and all morning and sleep sessions approved by the BRPT for continuing education credits. After a few minutes into each session, you will see a pop-up screen inviting you to evaluate the session and speaker. If you miss the pop-up or wish to fill out the evaluation later, simply click the blue button called Check-in Survey located on the screen above the name of the presentation. At the end of the day, you'll be able to download your certificate from within the conference site. Before we kick things off, I'd like to thank all of our speakers, sponsors, and DME partners. Sponsors, thank you for your support of this event. We would have a very difficult time offering this type of event without your support. We all have a choice of who we do business with. Please consider these manufacturers and suppliers. They clearly believe in the DME channel and investing in home care. DME partners, it's inspiring to see us band together for the benefit of our partners and patients. Today, we are all one team. Because of the valuable information being shared by our world-renowned speakers today, we will be better equipped to care for the millions of Americans with sleep and respiratory conditions. One more thing. Before each session, you're going to hear a little bit more about MSC from a few of our team members. To learn more about anything you hear and how we can support you and your patients, visit medicalserviceco.com. Now, let the forum begin.
Good morning and welcome. I'm excited to introduce the first speaker of the day. Our first lecture will be provided and presented by Dr. Dennis Auckley. Dr. Auckley is a professor of medicine at Case Western Reserve University MetroHealth Medical Center in Cleveland, Ohio. He has an undergraduate degree from the University of Virginia in biochemistry and his MD from Indiana University. He underwent internal medicine training at IU as well. Dr. Auckley then performed his pulmonary and critical care fellowship and training in sleep medicine at the University of New Mexico. Dr. Auckley is board certified in all 3 specialties. Dr. Auckley currently directs the Center for Sleep Medicine at MetroHealth Medical Center in Cleveland, Ohio, and performs research in sleep with a focus on sleep-disordered breathing among the inpatient population. He has published numerous peer-reviewed research papers and has written several chapters and reviews on various aspects of sleep medicine. Dr. Auckley is chair of the American Board of Internal Medicine Sleep Medicine Test Writing Committee, and he has served on national committees for a variety of medical societies, including the American Academy of Sleep Medicine, the American College of Chest Physicians, and the Society of Anesthesia and Sleep Medicine. Dr. Auckley is the immediate past president of the SASM and vice chair of the AASM, Inpatient Sleep Medicine Task Force. Dr. Auckley has provided various lectures for this forum over the years, and we are happy to welcome him as a speaker again this year. Today, Dr. Auckley will be discussing the role that sleep consultants have on the inpatient setting with a specific focus on evaluation and management of sleep disorder breathing. Upon completion of the lecture, Dr. Auckley will field questions that have been submitted by you relative to the lecture. Please submit your questions during the lecture by clicking the Engage tab above the presentation screen. So without further ado, I hope you enjoy Dr. Auckley's lecture titled Inpatient Sleep Medicine, Are We There Yet?
Hello, welcome to the Gene S. Marx Memorial Educational Forum. My name is Dennis Auckley. I'm a professor of medicine at Case Western Reserve University and director of MetroHealth Medical Center's Center for Sleep Medicine here in Cleveland, Ohio. I would like to thank Medical Service Company for putting together this forum today and for inviting me to speak. I'll be speaking to you over about the next 50 minutes or so about inpatient sleep medicine, which is an area that I've been interested in for a while. and something that really may be coming to fruition in terms of sleep medicine moving from the outpatient setting into the inpatient setting, something that we traditionally don't do. So just briefly, some disclosures. I am a site PI for the Sleep Smart study, which is a study actually looking at post-stroke patients in the inpatient setting and whether PAP therapy may help. And we'll talk about that during this study, although the talk will not deal directly with the study itself. And then also I am the chair of the Sleep Medicine Exam Committee for the ABIM. And I must tell you that there will be no questions, board type questions coming from the talk. And then I've written a couple of sections for Up to Date, for which I get an honorarium, and those are on inpatient sleep medicine. And then finally, which I will mention as well, I am on the American Academy of Sleep Medicine Task Force that is newly formed to look at the management of sleep disorder breathing in the inpatient setting. So what I'd like to cover in the upcoming time here is to discuss the reasons why we should think about sleep medicine in the inpatient setting and how we could develop sleep medicine consult services. Discuss some issues related to designing an inpatient sleep consult service because it's not quite as obvious as it may seem on the surface. And then we'll recognize some of the logistics of implementing an inpatient sleep consult service and review some of the just practical advice and pitfalls associated with this. So why should we consider having an inpatient sleep consult service? Well, we know that sleep is very poor in the hospital. Anyone that's been hospitalized will tell you this. Many patients we see in the hospital, this is one of their more common complaints. And the fact that they don't sleep well in the hospital, which is a time when they're acutely ill, trying to recover from surgery, trauma, and acute illness, poor sleep may actually be associated with adverse outcomes. We also know that sleep disorders are very common in hospitalized patients. And the main bullet points here are that they are underdiagnosed. They potentially could be associated with poor outcomes during their hospital stay. And then there's growing research suggesting that interventions may improve patient safety and some outcomes. So I'm just going to touch base briefly on poor sleep in the hospital. This is a whole talk in and of itself. But we know, again, as I mentioned, that this is a very, very common complaint. And there's some emerging data suggesting that consequences may be resulting from patients having fragmented, interrupted, poor quality, and insufficient sleep while they're hospitalized. One of those is impacts on cognition and neurobehavioral behavior. And there's been a fair amount of data suggesting that poor sleep in the hospital is a significant contributor to patients developing delirium, particularly in the elderly. There's data going back to the 1980s, which is now being looked at real world in patients in the hospital that suggests if patients are sleep deprived, it impairs their ability to breathe, so impairs respiratory function. And it may also impact immune function. So this is very important when patients in the hospital often fighting off infections. If their immune system is being further degraded by lack of sleep, that can be a problem. More recently, there's been some data as well about how sleep deprivation can impact glucose control and lead to difficulty managing diabetes while patients are hospitalized, in part related to a lack of adequate sleep. And then we know that poor sleep or inadequate sleep leads to a lowering of the pain threshold. So pain becomes more of an issue and patients will become more anxious, irritable, et cetera. Conversely, just trying to throw medications at patients to help them sleep in the hospital could be potentially dangerous. There are studies suggesting that a number of the medications that we may use in the outpatient setting may have enhanced side effects during the inpatient setting. Particularly some of the Z drugs, such as Ambien, may be associated with increased falls in elderly individuals if provided during the hospital stay. So we have to be a little bit careful and thoughtful about this. I just thought I'd highlight one study that was very interesting that came out just a few years ago, and it actually utilized a very modern research technique, which was flash mob research. This was a single-day, multi-center, cross-sectional observational study performed in the Netherlands. And this study was performed by having all the hospitals participate and try to get their patients in a single day to fill out a survey and a questionnaire related to their sleep during their hospital stay and comparing it to their sleep at home. And they actually were able to enroll over 2,000 patients in this one day. You can see the demographics there, a little bit older, about half male, and most of them were non-surgical patients. On average, patients reported sleeping almost an hour and a half less during their hospital stay than they would normally at home. And they frequently awakened during the hospital up to 1.5 times more than they would when at home. And this is not surprising, given that the frequent interruptions needed for patient care, but also factors such as noise in the hospital, light exposure, their acute illness, pain, difficulty breathing, things like that will all impact that. So this just highlights how poor sleep in the hospital can be. So I'm going to move on and discuss sleep disorders in the hospital. And most of what I'm going to talk about has to do with sleep disorder breathing, in part because that is the low-hanging fruit. It is very common, and we're all familiar and comfortable with managing it. But I am going to bring up just a couple of issues related to some of the movement disorders, particularly restless leg syndrome. There's been some recent studies looking at that during the hospitalized setting, and even narcolepsy, how that may play out once patients are admitted to the hospital. I'm not going to talk specifically about insomnias or parasomnias, but those are areas which there's little data, but a lot of potential for problems to occur when these patients are admitted to the hospital. So why should we care about obstructive sleep apnea in inpatient settings? We'll talk about obstructive sleep apnea, central sleep apnea, and hypoventilation, but mostly we'll talk about obstructive sleep apnea because that's where most of the data is. So first off, we know it's highly prevalent. It's a very common condition, and I think you guys all know this. Most of you deal with this on a day-to-day basis. But when patients who are hospitalized for a variety of conditions, we're probably looking at a very enriched patient population. So it is very common in patients that are admitted to the hospital. So just as a refresher, this is really what our most recent data in terms of prevalence of sleep disorder breathing in the general population is. This is from the Wisconsin Sleep Cohort Study, which was recruiting middle-aged state employees to participate in these studies, in which they went ongoing sleep studies over a series of years. And the latest information from their study, which is using an apnea-hypopnea index criteria of 4%, so very conservative, and 15 events per hour, so at least moderate sleep apnea. When you take men from all sizes and ages, about 14% of them would be considered moderate sleep apnea. And for women, it was about 5%. Obviously, the prevalence rates go up based on age. So the 50 to 70 group has more sleep apnea than the younger group, same with women. And then as their BMI increases, and so we all know this, that as you gain weight, sleep disorder breathing becomes more prevalent. But you get to a group of BMI over 40 in a middle-aged man, and their prevalence rate of sleep disorder breathing is 55%. So it's a very nice, well-done study, but it just sort of highlights what our baseline prevalence is when we're talking about sleep apnea. But now we start to look at patients that are coming to the hospital or to our clinics, but particularly those that are admitted. And we see that patients with certain comorbidities have very, very high rates of sleep disorder breathing. So when you look at patients who've had a stroke, it's upwards of 60 to 70% will have sleep disorder breathing, usually defined by an apnea-hypopnea index more than 5 or 10. Patients with coronary disease, congestive heart failure, atrial fibrillation also have very high rates, somewhere around 50% or more. There's high variability in some of the studies, but on average, it's around 50% or more of these patients will have sleep disorder breathing. And then many of the patients admitted to the hospital are diabetic. They have cardiovascular complications, infectious issues, et cetera. You can see very high rates of sleep disorder breathing, particularly in the type 2 diabetics. So when we're, again, looking at patients in the hospital, what we're probably looking at is an enriched patient population who has a lot of these comorbid conditions for which obstructive sleep apnea sort of coexist. This was a study that we did here at Metro a few years back, in which we actually just looked at medical patients on the floor. So these are patients admitted directly to the floor. And we did randomly selected patients to do formal polysomnograms in their room during their hospital stay. And they were admitted for a variety of reasons. It could have been cellulitis, asthma problems, diabetes out of control, et cetera. And what we found was that almost 80% of the patients using the more liberal criteria of 3% desaturation would be considered to have obstructive sleep apnea. And if you want to look at the more moderate severe group, it's over 40%. This patient population, the average age was 47 with a BMI of 30, so they're not particularly obese population. Interestingly, we went back into their medical records just to see what the primary team caring for the patients thought, and if they ever did bring up the issue of sleep disorder breathing. And only 2 of the 88 patients were suspected by the primary team of having sleep disorder breathing. So it appears to be, even just in medical inpatients, quite a common disorder. but often not recognized. One can often argue that when these patients are studied in the hospital, that the inpatient study may not actually be reflective of what's happening in the chronic outpatient state. So we did get a subset of our patients to come back for outpatient sleep studies, confirm their diagnosis. And what you can see, this was, I think, around 16 patients or so. Everybody that had sleep apnea in the hospital of this group still had it when they were looked at within 3 months of discharge. Most notably is that while some patients remained the same, there were some that actually got a little better in terms of their apnea-hypopnea index, but there were some that are actually worse in the outpatient setting, which may reflect increased time in REM sleep or sleeping on their backs, et cetera. So the main message here is that if they were diagnosed during the hospital stay, they still had it as an outpatient. So this is just representing a chronic condition. So why else should we care about it? Well, we know it's underdiagnosed. So I just provided you some information about that, how it's underdiagnosed in the inpatient setting, but we know it's missed in the outpatient setting. This was another study that we did at Metro. And this is not unique to our institution. There's been numerous studies using various methodologies have shown the same thing across the country. But what we did in this study was we took about 100 patients that were coming in for new patient appointments to the family practice clinic. And we, on exit, when the patients were done with their appointment, we had them fill out a couple of questionnaires, one which was a STOP questionnaire, and the other was the Berlin questionnaire, which is embedded in the Cleveland Sleep Habits questionnaire, both which have reasonable predictive values for obstructive sleep apnea. And we found that about a third of the patients would be considered at high risk by either of the questionnaires for having sleep apnea. However, when we went back and looked in the records, again, only 2 of the patients were suspected of having potential sleep disorder breathing. And this was by looking at their history, present illness, review systems, assessment plans, et cetera. So it was very commonly missed in the outpatient setting. And we know that it's missed in the inpatient setting. I already showed you data from our institution, which was a small prospective study of objective testing. Here's 2 other studies. This one was from 2010, in which they looked at a national hospital discharge survey database of 2.4 million hospitalizations. They looked at the ICD codes for obstructive sleep apnea, finding that it was very uncommon that obstructive sleep apnea was listed in the diagnostic list. And then of those patients that were listed, almost none of them were put on PAP therapy during their hospital stay. A similarly large study looked at just specifically patients admitted to the hospital for pneumonia, 250,000, again, a large database. This was from 2014, so a little more recent. They found that 6% had a diagnosis of obstructive sleep apnea in their ICD code. So better than what it was, but still well below that prevalence, which we'd see in sort of normal, healthy community dwelling population. So why else should we care? Well, obstructive sleep apnea does have consequences. And this may be associated with adverse outcomes in the inpatient setting or in the short-term post-operative or post-discharge period. So we know there's a lot of emphasis on readmission rates and patients coming back to the hospital and trying to prevent that from happening. And it's possible that obstructive sleep apnea could be a potential target for this. So some of this data comes extrapolated from the perioperative setting. So there's a fairly robust body of literature that has looked at sleep apnea in the perioperative setting. And we know it's associated with adverse outcomes, particularly cardiopulmonary outcomes. And there's a number of reasons why this is. Obstructive sleep apnea is associated with significant hypoxemia at baseline. Now you give them opioids and anesthetics, that's likely to get worse. The surges in sympathetic activity during sleep could cause adverse problems while patients are admitted. Most patients with sleep apnea are obese, but not all of them. Obesity does have some impacts on the respiratory system, which puts patients at increased risk for problems when you add in additional factors, such as low oxygen stores and impaired respiratory mechanics. And then many of these patients that we already mentioned have significant comorbid conditions that may put them at higher risk for problems during hospitalization. So a lot of them have cardiovascular disease, diabetes, et cetera. Because of their crowded airway, they're often difficult to intubate and extubate. And then we know that anesthetics and sedatives, as well as opioids, all have adverse consequences on apneas and hypoxemia. So they tend to make the airway more prone to collapse, which makes apneas more frequent. And then in addition, they tend to suppress the arousal response, which normally gets a patient out of an apnea. So that would predispose the patient having longer apneas and potentially more hypoxia and more hypercapnia. And then oftentimes patients are required to be on their backs following surgery. So supine positioning, and about half patients have supine worsening of their sleep apnea. And then there's a potential for REM rebound 2 to 3 nights out after surgery. Patients awfully don't sleep well the first night after surgery. Their sleep is highly fragmented and they do not get into the deeper stages of sleep. So this is all perioperative problems. What about just general inpatients? When you look at those patients, many of the risk factors are still there. They're not being put under anesthesia, so they're not having to go intubation, extubation, through intubations or extubations. They're not giving anesthetics, but they may be getting sedatives, and some patients do get opioids as well who are not getting surgery. And then some are required still to be on their backs for a variety of medical issues as well. So the risk factors are still there. So does this translate into worse outcomes for these patients? When we look at some of the groups where we consider sort of low-hanging fruit, so particularly the patients with coexisting cardiovascular disease or undergoing an acute cardiovascular illness, one of those groups is the post-stroke patient population. And we know that in patients who have had a stroke and they're subsequently found to have sleep disorder breathing, particularly obstructive sleep apnea, then short term, their recovery from their stroke tends to be worse. They have worse functional outcomes. They're more likely to manifest depression. Long term, these patients are going to be at higher risk for having a second stroke and increased risk for early mortality. And it's thought that obstructive sleep apnea is a causative factor in these outcomes. When you look at patients coming in with acute heart failure exacerbations, this was a study, looked at 100 patients, just did a simple overnight oximetry, and they looked at the oxygen desaturation index, which roughly correlates with an apnea-hypopnea index if you're using a 4% desaturation criteria. And they found that those that had high oxygen desaturation indices, consistent with sleep disorder breathing, were much more likely to be readmitted and had higher mortality at 4 months post-discharge. Dr. Kayat, who was previously at Ohio State, had a large program there in which he worked with a cardiology service, and all patients coming in with acute heart failure exacerbations underwent limited channel portable studies prior to discharge. And what you can see here is they did look at survival out from the time of discharge from that acute admission. And the black line are patients that were not found to have sleep disorder breathing. And then you have the blue and red line. And the blue line represents patients with obstructive sleep apnea. And you can see as early as 3 months, there starts to be a separation where these patients who have obstructive sleep apnea and heart failure, their survival starts to go down out of proportion to those who do not have obstructive sleep apnea. And a note, they did not enforce that these patients be treated. They were sent back to their primary care doctors and recommended treatment, but most of them were not on therapy. Likewise, another smaller study, but looking at patients, again, with obstructive sleep apnea index using the 4% desaturation criteria and moderate the HI-15. It's a study out of Mayo Clinic. They looked at major adverse cardiac outcomes, so death, reinfarction, new stroke, significant arrhythmia, or heart failure admission. So likelihood of having this. So patients that had sleep apnea, again, this is post-discharge. You start to see separation in this study at about 6 months, and by 12 months, it's significantly worse. So higher rates of these problems in patients found to have sleep apnea during their admission. And this was particularly predicted by 2 factors. So one was the degree of hypoxemia that was seen on their sleep study. And then secondly, just how sleepy these patients were. So we know from previous literature that patients who are sleepy are more prone to adverse cardiovascular outcomes. And so this study verified that the patients diagnosed during hospitalization who were more hypoxic and more sleepy had worse outcomes when you looked at cardiovascular outcomes over the short term post-discharge, so as early as 6 to 12 months. So when we talk about just general medical patients, so we talked about post-stroke patients, heart failure patients, cardiac patients. Patients just admitted to general medical floor. Dr. Sharma, who was at an institution in Philadelphia and now is at the University of West Virginia, did a lot of screening work with patients being admitted to the medical floor. And he used just the STOP questionnaire, which just asks about snoring, tiredness, observed apneas, and high blood pressure. If you have 2 or more of those positive, you're considered high risk for sleep apnea. And he found that those that were at high risk, their need for rapid response team intervention during their hospital stay was almost double that of patients considered to be at low risk. So these patients were not acutely treated. They were just identified as being at risk for sleep disorder breathing. And then they went back to look to see what happened during their hospital stay and found that their RRT activation was significantly higher than those considered to be at low risk for sleep apnea. So what about treatment? Does treatment impact their outcomes? So again, looking at some of the specific groups in the post-stroke patient population, there's actually been a number of very small studies. I'll just show you two real quickly of patients coming in with an acute stroke and then being placed on therapy for verified or suspected sleep disorder breathing. And these are both randomized controlled trials that I'll present, fairly small, but they did show that at 1 month in the group that was placed on AutoPAP, most of them were able to tolerate it, and they had a better NIH stroke scale, means better improvement in their stroke recovery in those that use CPAP. And the more they used it, the more hours of use they did, the better their outcome was. And another small study, similar numbers, only 40-some patients, looked at 1 month outcomes, CPAP plus usual care versus usual care in these patients that had a stroke and were diagnosed with sleep disorder breathing after their stroke. They found improved functional motor outcomes at 1 month, but interesting, no change in the neurocognitive outcomes. So as a result of these studies and a couple other small studies finding similar sort of findings, although differing a little bit in which outcome was improving, that led to this development of the Sleep Smart study, of which we're one of the sites. There's actually over 100 sites in the country participating. And this is a study which is looking at patients coming in with acute strokes, and then they will undergo testing, a limited channel study in their bedroom within hopefully a few days of the stroke. And those that have obstructive sleep apnea, using a definition of apnea of index of more than 10, and a minimum and minority of the events have to be central apneas, that those that meet criteria will then be offered a night of auto CPAP. And then those that tolerate it and use it for at least 4 hours, they would then go on to be randomized into either just usual care or usual care plus continued use of the auto CPAP. And then they're going to look at 3-month and 6-month outcomes. So 3 months looking at their functional recovery from their stroke and their quality of life. And then 6 months looking at more cardiovascular outcomes in terms of recurrent events or new events. So this study is hopefully going to enroll over 3,000 patients nationwide, and will hopefully provide some answers as to whether CPAP utilization in this acute setting in the hospital, starting it there, will help with these patients who've suffered a stroke. Again, Dr. Sharma's data looking at patients admitted with heart failure and were diagnosed with obstructive sleep apnea or central sleep apnea within 4 weeks of their discharge. So these are patients that went to studies shortly after discharge, and they looked at those that were prescribed PAP therapy and were compliant versus non-compliant. And they looked at the total number of clinical events, which is readmissions or ER visits before and after the initiation of their PAP therapy at a 6-month outcome point. You see that those who were using PAP therapy had a dramatic reduction. So the yellow bar represents prior to their diagnosis and initiation of therapy, orange is after. So a dramatic drop in the number of clinical events in those that were compliant with PAP therapy, whereas you looked at those that were non-compliant, there was essentially no change. And again, looking at heart failure patients, Dr. Kayat did look at the patients that ended up on CPAP. Again, it was not randomized controlled data, but it was observational, and a number of the patients did end up CPAP, some did not. And when you look at again, the green here represents the sleep apnea patients, the black are patients without sleep disorder breathing. It's looking at percent survival out from discharge from the hospital. And you see the black line here. And then the green line are patients with obstructive sleep apnea that were put on CPAP. So their survival is very similar, actually maybe a little better than those without sleep disorder breathing. But if they had sleep apnea, were not placed on PAP or did not tolerate it, did not use it, their outcomes were down here, suggesting that they were doing much worse with lower survival, again, separating out as early as 3 months. Just another small study looking at patients coming in with a mix of cardiac issues, heart failure, MI, or arrhythmia. Most of them had sleep disorder breathing using a AHI 3% of 5. And then they placed them on AutoPAP and looked at readmissions just in the first 30 days. Patients that were fully compliant in that first 30 days, none of them were readmitted. Patients that didn't use it at all, you see they start to be readmitted after 10 to 14 days. And likewise, patients that only partially use it, so are poorly compliant with their PAP therapy, also start to be readmitted at a similar rate. So again, suggesting that in these patients with acute cardiac conditions, if they're diagnosed with sleep disorder breathing and initiate on therapy during their hospital stay, it may reduce their readmission rate in the short term. And then finally, another one of Dr. Sharma's studies, again, patients high risk for sleep disorder breathing. And they looked at some of these patients did end up getting placed on PAP therapy empirically. And they looked at that RRT rate. Remember, it was much higher if you had high risk for sleep apnea on the STOP questionnaire compared to if you did not. So now they're looking at patients that were high risk for sleep disorder breathing and were put on PAP therapy and actually used it. And you can see during their hospital admission that their rates went down dramatically if they were using PAP therapy compared to those who were not using PAP therapy. So to summarize the obstructive sleep apnea portion of this, it is very common in hospitalized patients, particularly in certain patient populations, those with cardiovascular disease being the most common. It's frequently underdiagnosed. It's missed in hospitalized patients. We know it's missed in the outpatient setting. The inpatient setting may provide an opportunity to capture these patients, but that's often not the case. And then increasingly, data are finding that obstructive sleep apnea is associated with worse outcomes, not just in the long haul, but in the near term. So meaning potentially worse problems during their hospital stay, but particularly in the short term post-discharge. And then there's growing data, although I don't have conclusive data yet, but data certainly suggesting that treating these patients or initiating therapy during their hospital stay may help to improve some of these outcomes. So what about central sleep apnea? So there's not that much evidence really looking at this. We know in the post-stroke patient population, central sleep apnea only occurs in about 7%. So almost all the patients with sleep disorder breathing have obstructive sleep apnea. It may be associated with intracranial hemorrhages or brainstem lesions. If it's intracranial hemorrhage, those tend to get a little better over time without needing specific therapy. A brainstem lesion obviously would not. When you look at the heart failure patient population, and Dr. Kayat did look at this patients with heart failure and central sleep apnea as well, because it can be very common in patients with reduced ejection fraction heart failure. And this is looking at the percent that are have a number of readmissions. And you can look at the central sleep apnea versus no sleep apnea. What you can see, the more they're admitted, the more likely they were to have central sleep apnea versus no sleep disorder breathing. So again, suggesting the patients with central sleep apnea are more likely to be readmitted in the first 6 months after discharge compared to those that are not. And when you look at survival, again, from his database, I didn't highlight this earlier, but the red line are the central sleep apnea patients, and you can see they perform as poorly as the obstructive and probably worse in terms of their percent survival post-discharge from the hospital. And then again, in his database, there were patients that were put on PAP therapy, again, not randomized or controlled. But you can see the red line here again is the central sleep apnea patients diagnosed during their hospitalization. And those that use PAP therapy, their survival post-discharge mirrored those of who did not have sleep disorder breathing, or those that had obstructive sleep apnea or on PAP therapy, which is much better than those that were in central sleep apnea but did not use PAP therapy. So about sleep-related hypoventilation. This is something we see very commonly in our hospital, particularly with a lot of the respiratory disorders as well as obesity issues. Unfortunately, there's very limited evidence. Actually, quite an old study. There's a retrospective review looking at patients admitted to the hospital who had BMIs more than 35, of which 47 of them met criteria for obesity hypoventilation. And compared to those that just had simple obesity alone, those with obesity hypoventilation had much higher rates of transfer to the ICU, although this wasn't quite significant, but close. Much higher rates of need for mechanical ventilation, which is not a surprise because many of these patients are coming in respiratory failure. And then they had higher rates of being discharged to a long-term care facility and not going directly home. And then mortality, as might be expected, was significantly elevated in these patients in the first year and a half after their admission, which was in part possibly related to their hypoventilation problem. So we know that these patients, if they are admitted to the hospital, they tend to do poor and worse than those who just have obesity, and worse than those actually just have obesity and OSA. So if you have obesity, OSA, and hypoventilation, those patients tend to do the worst in terms of their outcomes. So I mentioned at the start that I'm part of a task force. So I'm just going to briefly discuss this because we're kind of in the middle of our work and hoping to have some information, answers, guidelines in this realm. So we're actually just looking specifically at inpatient sleep disorder breathing. And the questions we're asking are in adult patients, so we're only looking at adults, at risk for sleep disorder breathing. So these may be screened for high risk, but are not formally diagnosed. Should we be screening them during their hospital stay? Should we be doing inpatient studies during their hospital stay? And we'll talk about that a little bit later. And then in adults at risk for sleep disorder breathing or with known sleep disorder breathing, but not on treatment, who are admitted to hospital, should we initiate treatment during their hospital stay, primarily with PAP, but there are alternative therapies, including oxygen. And then in patients at risk for sleep disorder breathing or with known sleep disorder breathing, but on treatment or admitted to the hospital, should we initiate PAP therapy or perhaps continue it? So we'll be looking at that body of literature as well. And then in patients at risk for sleep disorder breathing or have known sleep disorder breathing with or without treatment or admitted to the hospital, is there a role for an inpatient sleep consult service? So we're going to look to see if there is literature supporting or refuting that. And then should these patients undergo some sort of enhanced monitoring? Generally, we're talking about physiologic monitoring like continuous oximetry or perhaps CO2 monitoring. And then finally, in these patients who are in the hospital and found to be at risk for sleep disorder breathing, what should their post-discharge management plans be? And should they be being sent directly to sleep medicine to help with evaluation and management? So I'm going to shift gears a little bit and just talk briefly about restless leg syndrome. Inpatient providers will see patients with restless leg syndrome. We know that 5 to 10% of the patient population suffers from this condition. For those not familiar with it, it's a condition in which patients have an uncomfortable sensation in their legs, often an urge to move, but they may have all sorts of strange sensations. This typically occurs at rest, and there's circadian variability, meaning it occurs mostly at nighttime. It often gets better with rubbing, walking, getting out of bed. It can cause impaired quality of life. It can cause insomnia and sleep deprivation. And for some patients, because of the recurrent jerking and the autonomic surges associated with it, it may be associated with some cardiovascular outcomes, although that's not clear at this point. When patients with restless legs are admitted to the hospital, oftentimes their medications, which can be very, very effective at controlling this condition, are stopped, which may put them at risk for rebound. And then medications are often started, which can aggravate restless leg syndrome. So things like antihistamines, dopaminergic antagonists, antipsychotics, and SSRIs, antidepressants, can cause problems. Patients in the hospital often become anemic from either acute bleeding issues, surgery, trauma, frequent blood draws. We know that low iron stores is a big aggravator for restless legs. We already talked about how patients in the hospital become sleep deprived, and we know that's a big aggravator for restless leg syndrome as well. And if you ever want to torture a patient with restless leg syndrome and make them sit still, immobility is a big problem. They have difficulty doing that. It's very uncomfortable for them, and patients admitted to the hospital sometimes may be required to be immobile due to their condition. And then when patients get spinal anesthesia, there's been some case reports about that may actually kind of worsen things. So just to highlight this, there was a case reported a number of years ago. This was a 74-year-old female who had known restless leg syndrome. She was undergoing a simple lumpectomy for newly diagnosed breast cancer. Her restless legs had been well controlled for 3 years. She was on dopaminergic agonists for this. The night before, she was told to take an antihistamine to help her sleep. Of course, as I just mentioned, antihistamines will worsen restless legs. She actually was up most of the night pacing, so she came into the surgery sleep deprived, irritable, and uncomfortable. Fortunately, her surgery went well, but in the PACU, she experienced severe restless leg syndrome, and it actually started to involve her upper extremities, which can occur. And this motor restlessness led to a breakdown of her wound, and she developed a large hematoma and then had to go back to the operating room to undergo repeat general anesthesia to evacuate the hematoma and seal things up. As a result, she had drops in her blood counts, iron deficiency anemia, and so things just got worse. And it took 1 month for her restless leg symptoms to get under control following the surgery, and she described it as being suicidal-like. Anecdotally, I've had some patients that have had similar experiences in terms of having very difficult times when they're in the hospital with their restless legs, being very uncomfortable and impacting their overall care. Unfortunately, the literature to date really is limited to case reports and brief case series. There's no potential complications and concerns that have been raised. This includes altering the surgical procedure and anesthesia plan. So I did have one patient that when they were planning to do a regional anesthesia and they put her on the table, but her legs were kicking and jumping so much that they had to change the plans and put her under general anesthesia. I talked about the case report there that you can have compromising of the surgical site and increased postoperative bleeding. A lot of times these patients become tachycardic and hypertensive if their restless legs are really out of control. Of course, the first thing hospitals may think about is, are they having a blood clot, and send them off for necessary testing or treatment. And then the restless legs can cause sleep deprivation, insomnia, which then can worsen the restless legs. So you can kind of get this vicious cycle. And we already talked about how that can impair healing and impair your immune function and increase your risk for delirium. And then not to mention the patient quality of life can deteriorate. So briefly, a couple words on narcolepsy. So we know it's relatively uncommon, but there's been some increasing literature looking at this in the perioperative environment, but this could be translated into the medical environment as well. So these patients will be admitted to the hospital. There's been concern raised about patients with narcolepsy undergoing anesthesia and sedation, particularly because of problems with their hypersomnolence, leading to prolonged emergence and postoperative hypersomnia. They can also be at risk for increased perioperative cataplexy and sleep paralysis. There could be potential drug interactions with the medications used to treat their narcolepsy with anesthetics. Conversely, if those medications are stopped abruptly, that can lead to withdrawal. We know that patients with narcolepsy actually have a low pain threshold, and this may impact their ability to tolerate pain in the surgical environment. And then there's been a fair amount of studies suggesting that patients with narcolepsy also have autonomic dysfunction, meaning that blood pressure, heart rate variability are considerable. And this may be altered during an acute illness. So we tried to do a systematic review looking at this issue, but it was really limited to mostly case reports and small case series, and it was hard to come up with any firm conclusions. Following that systematic review, this study came out of the Mayo Clinic, which was very interesting. They did a single center retrospective review using 1 to 2 matching for patients. So matching on, age, gender, BMI, et cetera. And they looked at the patients who had narcolepsy and underwent surgery and compared to patients without. And they looked at 3 specific time periods. So phase 1 recovery is basically in the PACU. They looked at the first 48 hours after discharge and then 30-day post-op outcomes. And they didn't find any difference in any of these parameters with the exception of emergency team activation. So again, RRT, rapid response, having to come see these patients. So that was higher rate in the patients who were narcoleptic. And they found that these were related to hypotension, tachycardia, sepsis, and respiratory depression. So this could go in line with the autonomic dysfunction that I mentioned earlier, although the data is not conclusive. And then actually a fair number of patients with narcolepsy do have sleep disorder breathing and may be prone to developing respiratory depression in the postoperative environment if given opioids, coming out anesthetics, et cetera. So again, interesting information, but nothing that we can really firmly hang our hat on at this point. So why should we consider it? Well, sleep disorders are common. They're underdiagnosed, potentially associated with adverse outcomes, not just sleep apnea, but other sleep disorders as well. And then interventions may play a role in improving patient safety and some outcomes. And most hospital providers are not going to be very familiar with these interventions that we use in the sleep world. So some issues to consider with a sleep consult service. So first is what type of service would you want to do? So there's this call us if you need us, which is basically kind of outpatient sleep medicine. Most of the time when this happens, it's if a provider is going to be thinking about a sleep issue in the hospital, and I already pointed out that that's pretty unlikely to happen. And most of the time when these consults roll in, it's going to be, we'll see them in clinic. So that's kind of a very low level consult service. A sleep apnea only consult service could be developed. So this would be a service that might do proactive screening in certain areas of the hospital, for instance, the cardiac intensive care unit, the neurologic unit, areas where rates of sleep disorder breathing would be very high and screening may have a high yield. Or you could consider a full sleep medicine consult service where you actively seek out sleep disorder breathing for evaluation and management, open up for all other sleep disorders, including the parasomnias, the insomnias, the hypersomnias, the movement disorders, circadian rhythm problems, addressing poor sleep in the hospital, which is something that probably really needs to be done on a broad, systematic approach that'll involve the whole hospital and the administration as well. So where will the service be offered? For single center institutions, it's not a big deal, but for some places, a lot of places now have multiple sites. So are you going to offer it at your smaller satellite hospitals? Is it going to be throughout the entire hospital or just targeted units like areas I mentioned previously? Is the service can be offered 24/7, like many consult services are available, or is it going to be limited just to weekdays, 8 to 5? What about coverage at night? Who will be managing that? Is that going to be the sleep providers, fellows, respiratory therapists, sleep lab, et cetera? Then who's going to provide the service? So it actually involves probably multiple areas. So you definitely would need your sleep physicians involved, although interest is going to vary based on their background and their interest. So sleep providers who have pulmonary and neurology background may be more interested in doing inpatient sleep medicine than those coming from different backgrounds. It will generally need to involve the sleep lab, involving your technicians and testing equipment. Respiratory therapy are already out on the floors. They're very familiar with PAP therapy. They have some understanding of some of the testing that we would recommend. So they may be involved depending upon the politics of the local institution. Nursing support is key, as well as other providers, and then collaborating services. So if not already involved, sleep medicine would need to work with pulmonary, cardiology, neurology, PM&R, who handles a lot of the post-stroke patients, psychiatry potentially. Decisions have to be made about what kind of testing you would offer. So again, screening questionnaires versus doing nocturnal pulse oximetry versus doing home sleep apnea or limited channel testing versus doing full PSG in the inpatient setting. I'm just going to touch base on these briefly. Screening questionnaires have been well studied in the outpatient setting, and they're actually fairly accurate, although the big caveat is that they have low negative predictive values. So patients score negative on these, it's not always the case. They haven't been studied very well in the inpatient setting. In our study where we did PSGs, we did look at a number of questionnaires for these patients as well. Probably the stop bang questionnaire performed best with a sensitivity around 73%, positive predictive value around 76%, but still not that good in terms of negative predictive value. Certainly performed much better than the Epworth and better than just a stop questionnaire. The Berlin questionnaire is a bit more cumbersome, and the stop bang performed better than that. However, it's not optimal. Screening is still better than not. Again, as I mentioned, if we leave it up to us to look for this, it's a problem. So nocturnal pulse oximetry is something that's very easy to use. It's very inexpensive. If you're just looking at desaturation index and using that as your criteria for sleep apnea, it's actually reasonably accurate area under a curve of 80 or 0.83. And you could use it as playing a role in risk stratifying. So trying to just identify our patients really having a lot of desaturations or very hypoxic during the study. Disadvantages, obviously, you can have technical failures. No one's monitoring it. If patients are on oxygen for another reason, it's not going to be as useful. You cannot distinguish between types of sleep disorder breathing if it looks like it is present. You can't qualify patients for treatment based on a pulse oximetry. And then unfortunately, just the physicians, how they interpret these has been shown to be highly variable. That brings us to home sleep apnea testing. So obviously, again, this is really relatively simple devices, depending on the device. Some are easier to use than others. Certainly not as expensive as a PSG. Some devices can accurately distinguish between obstructive and central events. And generally, you can make a diagnosis in order to qualify patients for therapy with these devices. However, they do run the risk, again, of technical failures. So if probe comes off in the middle of the night, no one's watching the data real time, so that the study could be wasted. You can't monitor CO2 with these devices. Generally, you're not going to get reimbursed when these are done in the inpatient setting. Again, if they're on oxygen, it'll be less useful. And it requires a resource investment in terms of having enough devices, as well as having the personnel available to put the devices on and take them down in the morning. And then the gold standard would be the old PSG. Obviously, its advantages are it's their best test for sorting out what's going on with sleep and sleep disorders. If it's being monitored, you can intervene in real time. You can start PAP therapy during it. But in the inpatient setting, it's very cumbersome to do. You can still have technical failures. Quality of the data can be poor, particularly if patients are up frequently because of an acute illness or a lot of nursing interventions. It does require a fair amount of resource in terms of personnel as well as equipment, and then you're unlikely to get reimbursed for this as well. So those are things to think about in terms of testing, but you also have to think about therapies as well. And particularly for sleep disorder breathing, are you going to have the full range of things that we might use in the sleep lab? So CPAP, AutoPAP, bi-level, auto-bi-level, adaptive servo ventilation, volume assured pressure support ventilation, ventilators, et cetera, and who's going to manage these real time. For other sleep disorders, you need to find out what kind of medications are available in the inpatient setting. So just to kind of put this all together and come close to wrapping up here, there'll be a study coming, or not a study, a review coming out in CHEST sometime in the next few months, done by Dr. Sharma, who I mentioned already a couple of times. He's instituted this, what he calls a CEATCOM consult service at his institution, in which they screen for sleep disorder breathing in their very high-risk patient population, so the heart failure, the stroke, and the COPD patients, and those that are obese. They use the STOP or the stop-bang. They do education and evaluate the patients to determine whether what they use as a high-resolution pulse oximeter versus a home sleep apnea test would be most appropriate. They do acclimation of PAP therapy for patients that have a positive test and are high risk, so to try and get them on PAP therapy during their hospital stay. So they educate them about this and give them, let them practice with it, and then try to get them to use it during their stay. They adjust the treatment, so treatment adjustments. And then they work really on communication and coordination on discharge needs. So it's takes a lot of collaboration and communication to make this work. Interestingly, they looked at 2 1-month time periods. So 1 month, the year before they instituted their protocol, and 1 month after. And they looked at patients diagnosed with sleep disorder breathing in the hospital. And you can see here in the 1 month prior to their protocol, it was around 1 or 2 patients. Afterwards, it was up close to 150 patients just in 1 month. So those are just how much this is missed during routine hospital stays. So in order to make this happen, you really have to plan well in advance. You decide on the goals of the service that we mentioned and your resources. And then it will take a number of meetings to coordinate how this is going to work with both the sleep providers that will be involved, the sleep lab itself, respiratory therapy, DME companies, because often to get these patients on therapy going home, you'll need their input and support. You'll need administration's buy-in, and also have to talk to your revenue folks about what is billable and what's not. And then your collaborating services that I already mentioned. There are protocols and algorithms that are being developed. And so, looking at the literature to see what's out there and what can be feasible at your institution. Most places have electronic medical records now, which can help. You can protocolize a lot of things through that in terms of screening and identifying patients. If you have a large center that has satellite campuses doing e-consults, may be a way to go. It's very important, again, to coordinate and make sure that the transition to outpatient care is done properly. Otherwise, patients may fall off the map and be lost. The service should be marketed once you decide to go with this and pieces are in place. And then once started, you have to actually review what you're doing, reassess over time, because there's going to be changes that will need to be made. Some things won't work, some things will work well, and you have to make some adjustments and revise your plans as called for. So to summarize, are we there yet? Well, there's growing evidence supporting the need. It certainly can be done, as evidenced by work at some institutions, and it probably should be done, really looking at the information that we have now. As I mentioned, there's protocols and pathways that are emerging to help, but it will require a lot of careful planning and resource to determine how best to implement this in your own institution. So it really depends upon what your institutional infrastructure is like and what your resources are available in order to make this happen, as well as the motivation and interest in all vested parties. So with that, I will go ahead and finish, and thank you for the opportunity to speak with you, and I look forward to hearing any questions. Thank you.